Good morning, ladies and gentlemen. How are y'all doing? Are y'all enjoying yourselves? Yay! We are so happy to have you. I have one small housekeeping request, if you guys can help me out here. This is a beautiful facility, and with the beautiful facility, you can imagine that there comes some regulations. So we ask that if you have any open containers or any food, that you please dispose of it prior to coming into the auditorium. Food is welcome everywhere else on this level except for the auditorium. If you have a closed or covered container, then you're absolutely fine. Just please make sure that you dispose of it at the end of the day. All right, thank you so much, and please enjoy your day.
Thank you, Sunday. So y'all know me. Hey. I'm Dazon, and it is my pleasure to introduce the moderator for our first panel of today. But, you know, biology calls, and so as we wait for Maressa to come back into the room, couple of things I wanted to do, because I know Vanessa's got a couple of clarifying questions that people have posed to her, and so have I. And I didn't want to bring up too much first thing in the morning because we have a long conversation to go today. But I just wanted to put this pin in what she was talking about in terms of some of the changes that are already happening in 2014, and why, on some hand, I would say how serendipitous is it that we are choosing, even after, let me just say, I walked up to the head of the division of HIV, AIDS, tuberculosis, and viral hepatitis, that's John O'Merman, several months ago and said, you know, what are we doing about the CDC's definition expansion? It's the 20th anniversary next year. And it was like I was talking to a deer in the headlights. He was like, so they've latched on, obviously, because they sent us some good folks who are going to share with us today. But it's important that we were just thinking about how to acknowledge this as a way to look forward to what we've learned and what opportunities, some people would call them challenges, problems, crises, that we have right now that would give us the same pivot that women in ACT UP had back in 1990, right? Well, I just want to put on the floor, because it's going to come up in probably some of our panels. What Vanessa was talking about is two specific things that I know of right now, in addition to this whole world of us renegotiating contraception and everything else about women's reproductive health, is that two things are already about. You heard us talk about the Social Security's inclusion of women so that women could get diagnosed with AIDS and get their benefits back in the early 90s. Well, right now, the Social Security has up for decision a change to the eligibility definitions of disabilities, including HIV disabilities, and the potential for removing the gender-specific language is on the chopping block right now. And so the Social Security's website is up, the proposed changes are up, and that we have an open period for comments between now and the end of April to go in and make our statement about why they should not change that. The second thing is that the president released his budget for 2015, and inside that budget, including the funding for the Ryan White Care Act, which is the single largest payer of HIV treatment and care for people living with HIV in this country who do not have other means to pay for their care or their very expensive medications, there's a specific part of the Ryan White Care Act that deals directly with women, infants, children, youth, adolescents. That particular part has now been proposed to be collapsed into another part of the budget, which means essentially, you know what happens in mergers? That's the first thing. And the second thing is in my head and in my heart, I'm hearing a signal to say that women, not so much. And that's what we have to have this conversation about today. So does that sort of help contextualize some of what we're talking about in terms of where we're looking at today? Does that help us? Yes. Okay. Thank you for that indulgence. All right, they forgot to mention that I also teach, so y'all know it might happen. Now it's my absolute privilege to reintroduce, for those of you who weren't able to be with us last night, Dr. Maressa Mandefra, who is the president and producer and the founder of Truth Aid. Dr. Mandefra is an interdisciplinary scholar and producer who draws from her background as a medical anthropologist and public health physician to craft textured narratives that explore the social determinants of health. I'm not even going to give up the brand new idea you came up with. But she, which I love and I'm on board, I follow you. and there's a whole lot more about Maretta in the program that you have, which, by the way, brilliant, beautiful program, Georgia State, CEC. Isn't that gorgeous? Well done. It's so reflective. What I think is critical about understanding, and this is sort of what Vanessa talked about in terms of intersectionality. From my own experience with Maretta, it's always the most amazing conversation, because I have to keep pinching myself and say, you know, you're talking to a medical doctor, right? But I'm talking to a medical doctor who, first of all, sounds like a hip hop artist, one. Two, who understands how, as a physician, to dig into what the cultural and the social dynamics are of engaging with patients, not only in the medical system, in her own office, but throughout the medical system. And that the way to talk about it isn't necessarily about producing one more research paper, but maybe it's about telling the story in the way that some of us hear it best, through film, through movies, through images, through the stories. And I just want to say big ups to Maretta Mandefro. And even if, you know, you won the Sundance and didn't get to the Oscars this year, I'm looking for you in the documentary section of the Oscars soon to come. Everyone, please welcome Maretta Mandefro, who will introduce our panel.
Daesan makes everyone sound good. She's good at that. I had a program up here for me.
Oh, I probably just took
I was freezing, so I left my coat on, but now I'm up here and feeling like maybe that's not the right move. Anyway, thank you very much for having me. It's an honor and a privilege. I've been thinking so much since last night. The conversation last night was very inspiring to me. Atlanta has a very dynamic community of people living with HIV who very openly shared a lot of stories and gave a lot of food for thought. And you know, this plenary, this symposium comes at a very interesting time. My own work has taken me to think about gender all across the world and really thinking through issues of violence. And we have another huge milestone coming up. And I've been like concocting ideas. It's the 20th anniversary of Beijing next year, right? The Beijing Platform for Women's Issues. And everyone in the world, literally like 6,000 representatives, are in New York City right now meeting at the UN to talk about the Commission on the Status of Women. So issues of gender are in the mainstream water. We are not on the margins anymore, right? But yet, as Vanessa so aptly captured, right, the more things change, the more things stay the same, right? And we have to ask ourselves, why is that? Why is it 20 years later we still continue to talk about this? And if you really think about that question, I think a lot of it has to do with, you know, thinking through what these barriers are. So in a fit of inspiration from all of you, I was thinking, you know, the CDC has your diffusion of effective behavioral interventions, your DEBIs. I think we need some time for DESIs, you guys, diffusion of effective structural interventions. We gotta move beyond behavior, y'all. We gotta move beyond behavior. That is the only way to attack this problem of gender. Because the reality is these categories can be sticky and they can keep our thinking narrow. So when we keep thinking about gender just within the context of women, we forget that it is a shared community of risk in these pockets of infection, right? You've got to bring the men into these conversations. And we forget to recognize that 20 years after Beijing next year, there is so much good work that men are doing in the name of gender. There is Men Engage, which is a global campaign. There's He for She, which launched last week. And we need to figure out in the HIV community how to tap into all of this because it affects us, right? We're in our silo. So I guess that's my hope. Let's bust out of this paradigm of thinking of behavior alone and really think creatively about how we can redefine this narrative of gender, right? It's tricky though, for the reasons that Daesan just said. You need these categories in order to get funding, right? So mergers can be dangerous for people that live in these categories, but the reality is It's like I used to always say this, patients don't think about diabetes on Monday, HIV on Tuesday, what am I gonna do with my kids on Wednesday? It's all happening at the same time, right? The lived experience of all of these things are very integrated, a la intersectionality and all of these other things. So I think part of the DESI discussion is this discussion of social determinants in general, right? And so as we have our continuum of care discussion, thinking about treatment, I challenge us to really think broadly about this continuum, right? Everything from primary prevention, right? Making sure that we have an AIDS-free generation, which I totally think is possible in the next 10 to 20 years, to making sure that 50% of women who are HIV diagnosed and not in care still in 2014. 50%, you guys, that is humbling. And then even fewer, 4 in 10 that are diagnosed that do not have the virus under control, even the ones that are in care, right? So that's the gamut. That is the challenge we have to think about. And I think the one statistic, just to keep it relevant, this statistic came out in 2009 with the World Health Organization's first report on women around the world, which in of itself is problematic, but let's let go of that for a second. 2009, #1 killer of women of reproductive age, HIV. #1 killer of women of reproductive age around the world. HIV, 2009, still. Okay, so with that said, I would love to bring the esteemed panelists up here in no specific order. Where's this? Okay, first we have Dr. Edith Biggers, sorry, she's the lead physician at the Ryan White HIV Clinic, Fulton County Department of Health and Wellness, Atlanta, Georgia. Anywhere you please. Oh, I get hugs in Atlanta. I love it, you guys.
That's right.
I love it. Stephanie Laster, who was on the panel last night, an HIV prevention specialist, peer advocate. Please join us. And then Sarah Vincent, who I did not meet, Dr. Sarah Vincent, founder of blackhealthnet.com and assistant professor of psychiatry. And you know mental health is a big part of this discussion, so I'm very excited in particular to have you. So I don't know how you want to do this. I actually did prepare some questions. So please sit, and I will sit with you so don't feel too weird. Is there enough seats for all of us? Okay. So I've purposely framed this discussion on the continuum of care abroad because we know now, many years later, treatment is prevention, right? And I'd love for you guys to share your insights from where you sit about why is it in 2014 that 50% of women who are HIV diagnosed are not in care? In other words, what are the top 2 barriers to linkages of care as you see it? You went first.
Hello. So as a adult and child psychiatrist, I always think about things developmentally. And in my work, I see a lot of children who are victims of trauma and adult women who are survivors of trauma. And a lot of times people think about PTSD when it comes to trauma, but you also have to consider depression. And depression is actually the most likely mental health disease outcome that's going to come after trauma. And with depression and with PTSD, there are these parts that don't get paid as much attention to as some of the other symptoms. But with depression, there's this sense of hopelessness. And with PTSD, there can be this sense of a foreshortened sense of future. And when you're hopeless about your future, or you're not invested in your future, or your future isn't necessarily something that you want or you aspire to have because living is so hard, or when you have a foreshortened sense of your own future and you don't see yourself in 10 or 20 years in any capacity, let alone a good one, it's hard to engage in preventative measures to preserve your life. It's hard to think that wearing a condom is important if you don't care about whether you live the next 15, 10, or 20 years. And so trauma and prevention of that, particularly for our young African American girls who are so vulnerable, is very important.
I can't tell you how many times I've seen girls in a family where the same person has traumatized multiple generations of women and girls. We cannot continue to not talk about it and to expose our children to these same people over and over again. We have to talk about these things more openly and protect our girls. And that's one way I think we can prevent things. The second is, and you may think, what is the psychiatrist doing talking about this? But part of why I started blackmentalhealthnet.com is because of the power of media and images and ideas and ideals and how people see themselves. And there's this rapper called Rick Ross, and he has this line that it infuriated me, but I think it really distills something that's at the core of a lot of these problems. And it says, "My chick is bad, looking like a bag of money." And I think it just summarizes this idea that women's bodies and sex is their currency and the most valuable thing that they have to offer to society. And we have to be careful about the images we put in front of our young girls and help them define themselves and their womanhood in terms of their accomplishments, their achievements, their abilities, and what they have to offer the world apart from sex. Because in doing so, we empower them in their lives in general, but also in the bedroom to be able to make somebody or require that somebody use protection when they engage with them.
So I have to interrupt you because in my excitement and enthusiasm and being moved, I forgot our fourth panelist who, it's ironic I forgot her because Dazon, you know, last night I said, that girl, Masonia, is phenomenal. I literally said that last night, so I feel particularly bad. So please welcome Masonia Trailer. She's an HIV/AIDS advocate, peer specialist, youth recruitment and retention for the African American Outreach Initiative. I am sorry, I was talking about you last night too. So please sit down. And thank you. Those were profound comments that I hope we could dig in deep. Dr. Biggers.
You know, first of all, I am so happy to be here, and I'm so happy to look out and see all of you. Just give yourselves another hand, if you will. I am so struck by the idea that the more things change, the more they stay the same. And I've been doing this work since probably about 19 years, and I'm still having the same conversations with my women, the same conversations, and I'm still having some of the same thoughts as I had when I first started. Things that have been mentioned already, things like the importance and the difficulty of negotiation. I call it sexual negotiation. You know, how do we get our women, young women of all women of all ages to feel empowered enough to have the conversations that need to be had, have the insight, have the strength to do it, have the immunity from violence. That's a big one, certainly. So often when I talk to my patients about safer sex, let's just take that for example, I get a lot, he doesn't want to wear a condom. And I'm always struck, I always have to stop for a minute and think, and I always ask, what about you? What are your feelings about what goes on in your relationship? And so that is a big thing. I think about that in some way every single day. And again, I'm having the same thoughts, not reaching any different conclusions as I did when I started. And I think that's something that needs to change. I think that is, yeah, I'll just leave it at that for just a moment. That's something that really, really needs to change.
Good morning. My comment on that particular issue it's kind of like threefold. I facilitate women's support groups on a regular basis, and we talk about things that sometimes we won't share with the therapist or the provider. And one of the things that was women don't want to get in care is because you have to acknowledge it. If I start going to the doctor and taking medication, then I got to identify with, I'm living with this virus, and I got to take a certain kind of responsibility. So if I'm not addressing it, then I don't have to think about it and it's not in my face every day. A lot of people don't want to step up because of financial situations. If I go back home and say I got HIV, then my bills might not get paid, or I might, violence can occur. And so I can't have the medicine because I'll get knocked upside the head. I can't let you know I'm sick because you're not going to want me and my children not going to eat. So we face a lot of issues that prevent women from wanting to step up and say, take responsibility and actually having to deal with it. And the other part is, I got to feed my children. I ain't got time to go to no doctor. I got to take off from work and go to the doctor. They got to eat. So it's different stories that I hear regularly.
I guess, can you repeat the question again for me?
Yeah, sure. The question was the barriers to linkage in care. Why is it 40% of women who are diagnosed or 50% are not in care?
Well, I think a lot of times what I realize when I'm speaking to people and just living with it myself, just as the rest of the panel has said, you have so much other things going on in life that when you feel fine and you think that everything is okay. And so it's very rare that you're encouraged to go to the doctor on an annual basis. It's just not a part of, your regular discussion. Me going to my mother, did you go to the doctor this year? Or going to my best friend and asking him, did you get a checkup this year? And it's like you're crossing these boundaries of inviting other people's personal space. So I think that is one of the barriers. But also for myself, I think that even now, from beginning until from the last 3 years since I was diagnosed, medical insurance and keeping it has been extremely difficult. And even though the Affordable Health Care Act is now available to me, just struggling trying to keep Medicaid. One of the things that I have realized financially for myself is I have yet to make over $1,000 a month being a mother of two. And I have been placed in a position where in order for me to get medical insurance through Medicaid, my income could not exceed $400 a month for a household of three. And when I say that, many people are startled by it, and then I realize that they're not aware of local policies. They think oftentimes that if you're receiving food stamps or you're below the poverty level, that that you're not a professional person or that you're not aspiring to do more in life. But financially, I have been put in a bind to make a decision, my medical health care or should I work? So I think that is one large barrier to linkage to care as well as treatment, because also the treatment is $3,000 a month for 30 pills. So without that Medicaid coverage, the other options that are available comes with taking the time out to go to these different local resources and applying for these things. And then that becomes a mental barrier because now I have to take the time to find childcare or take the time to to take the child with me. And then from there, it just becomes very overwhelming and you don't know which way to go and who to turn to.
Okay. Same question with prevention. What do you guys think are the barriers to prevention? Why are young women still acquiring HIV 20 years later, 30 years later, more than 30 years later?
Well, I guess my first response was really about prevention, because that's just how I think in terms of young people and mindsets. I think a big part of prevention, too, is addressing stigma. And it's been spoken on a few times already about how shame can stifle a discussion and stifle progress. And I think that events like this, where you have people who are living with HIV speak, because when you see actual people, it flies in the face of these boxes that stigma wants to put people in and put people with HIV in. And so addressing stigma, I think, is a big area of prevention, and awareness and people speaking up is a key part of that.
So wait, I'm going to push you guys because you guys are all brilliant. Is stigma the same now as it was even 20 years ago? To your point, I mean, I know stigma still exists, but sometimes I think stigma in of itself can be paralyzing, you know? Like, so please comment on that for other people as you're thinking about prevention, because it exists, but like, what's changed about it? Is there anything different?
One of the things that I realized for stigma for myself is when you're initially diagnosed, it becomes like self-inflicted stigma. So when I found out that I was positive, I didn't want to tell anybody. I didn't want anybody to touch me. I did not want, I became so upset that I just kind of isolated myself. The stigma became, I didn't even want to attempt to have sex and put anybody at risk. It became when I would get a paper cut, I would rush to find a Band-Aid because I worked in a pharmacy. And even though my colleagues may understand how to dispense medications and be cordial and nice to people or individuals living with HIV, I still would hear some of the things that they would say, letting me know that they did not understand. So it was mostly like self-inflicted in the beginning. And I realized that for a lot of people who are HIV positive, they have self-inflicted stigma before they even allow someone else to show it. Also, as a mother, my now 10-year-old, when he was 8 years old, you know, I asked him, I said, what would you do if mommy was HIV positive? Because he couldn't understand, why were we going to all these events around AIDS? Like, you know, why? And I had not educated him about anything yet because he's 8. I don't want to talk to him about sex yet. I'm HIV positive. I do need to talk to him, but I'm scared. I don't know how is this going to pan out for him playing with friends or what have you. So when I did ask him, he was like, well, I don't know. It doesn't, if you have HIV, I'm not going to hug you. I'm not going to kiss you. I'm not going to touch you. And then that's the first time I had felt stigma from the outside. And I had not taught him anything about HIV, but he just kind of consciously knew or thought that I'm going to die if I'm around anyone with it. And I said, well, you can't get it like that. It took for me to teach him that. So when it comes to prevention today, I realized that it's not just a lack of awareness and a lack of education, but there's something that skipped in our generation, that this history of ACT UP was not introduced to me until about 3 months ago. I had no clue about ACT UP. Who is that? And then to also realize and acknowledge the fact that at 27, Magic Johnson retired before I was even 3 or 4 years old. And Michael Jordan had retired when I was 5. So what the AIDS epidemic meant to me growing up was just get tested and know your status, and that was it. There was no history behind it. You knew that you could die from it. You knew that people were living with it, but there was no in-between understanding of where HIV had come from up until now.
I say stigma is still here, but it has changed. It's different because we're still thinking that because we're in certain financial circles or social circles or whatever, that it doesn't apply to me. You know, I'm not out there doing what they say can happen. We're not identifying with anybody, you know, just living your everyday life, falling in love, and doing what people in love do puts you at risk for HIV. When we're a certain age, we're invincible. I'm not going to get that. It's not going to happen to me. Another part is financial status. I know growing up, a lot of times parents are not able to do the things. So my girlfriend, she might have on the latest whatever. My parents not able to do it. That older guy, a couple of years older, he got a job. And if he's going to be buying me some things and he doesn't want to use the condom, if I'm weighing it out, shoot, I want to dress like my friends dress. And the condom then doesn't become an issue to me, because now it's like trying to live and be like the rest of the people around me. So those are some of the things that kind of presents issues with prevention and stigma, because the prevention piece is we talk it, we preach it. They even may have condoms in their purse. But if in the event the situation is, I give you $100 not to use a condom, then which would you do? That it's just a question we'd have to ask ourselves, depending on what it is you need. If you need your light bill paid or whatever, and the option is there, I'll do it, but I don't want you to use a condom. Then we have to think about, how. So we can teach and preach a lot, but everything is on an individual person basis. So how do we get the person to believe in themselves and know that I'm worth this, and whether you pay my light bill or not, it's going to get paid, and I don't have to stoop to what you want me to do. So here again, it comes to that emotional, mental, what do I think about me? How much do I love me? And, or do I worry about what you say more?
Dr. Biggers.
The more things change, the more they stay the same. Now, I think a lot about the idea of women feeling like they're not at risk, different groups of women feeling like they're not at risk. So, for example, seniors. Now, for everyone who thinks that seniors do not have sex, all right? Think again. Now, as I get older, this idea of being a senior kind of... I used to talk about those seniors, and now I got to talk about seniors like myself, okay? I like to call myself an elder, a wise elder, okay? But, we got to think, just as you were saying, if you don't think that something applies to you, then you're less likely to hear the messages that are directed at you. Oh, that doesn't apply to me. So I love to talk to people. You might notice that. People who know me know that. Gets me in trouble. And one of the best presentations I ever did was to a group of mothers at a church, okay? And it was at the time that Medicare D was first coming out, and somebody came and talked about that, and their little heads were nodding, and I thought, oh no, your head is not gonna bob when I talk to you. So I went up and I said, okay, ladies, I wanna talk to you about getting tested. Oh my gosh, those mothers were fiery. They said, what? Why are you in here talking to us about getting tested about HIV? We don't need to worry about that. And I thought, okay, let's have this discussion. So we're talking to a group of ladies for whom condoms represented, this is my contraception, this is my way of not getting pregnant, okay? Well, they were women past reproductive age, okay? So they're not even thinking about condoms as prevention for HIV or STDs, because of course, those nice men don't have those kinds of diseases, right? Just like Stephanie was saying. And so we had to explore, we had to have a long dialogue about that, about how things have changed, about the introduction of Viagra, Cialis, Levitra. And now we're changing the whole biology of men's ability to have erections, men's ability to have sex vigorously, and that has changed so much the landscape of who gets infected. And so I had to really talk to these women and say, listen, you might not know it, but you're in a group that's really highly at risk for acquiring HIV. And so I think that a lot of times women just don't think that they're at risk, that they're not in a group where they could possibly be at risk. And as far as I'm concerned, risky sex means you're having sex with somebody whose status you don't know. You don't know your status, and you don't know his or her status.
So my next question has to do, and I really don't know how best to phrase it, but what do you think because I think a very important part of the continuum of care is mental health, which is why I'm very glad you're here, Dr. Vincent. And this is a question to all of you guys, though. What do you think it is, both men and women, but in particular women, need to be mentally well? What are the resources that they need? Both, you can frame that however you want, from the ASO perspective, from like your family perspective, from the clinical perspective, really thinking through that question. What are like the top 2 things people need in your view to be mentally well, whole?
I think if I had to pick 2 things, I would say healthy relationships and a sense of purpose. And really those 2, I think, are the foundation. And even as you think about kind of mental health therapies and talk therapies and group therapies, that in a lot of ways they all kind of go back to that. And there's been all these studies kind of looking at different kinds of therapy, if it's psychodynamic or CBT or DBT or whatever, but what they found is that the relationship with the therapist is what matters more. The connection with the therapist is what matters more than whatever modality you use or however you're trained to do it. And I think that translates, the reason that works in therapy is because it's ideally kind of a microcosm of life. And so in larger life, the quality of relationships is what's really important. And from that quality of relationships, people are able to get that mirror for how they see themselves through how other people see them, and develop their identity that's hopefully going to lead them or point them toward some sense of purpose in their lives. And most people that I work with, if we can get those 2 things under control, regardless of whether it's bipolar or schizophrenia or depression or PTSD or whatever it is, if we can get them those 2 things, that's a big part of the battle.
Healthy relationships. I'm going to keep a list. Healthy relationships, sense of purpose. Dr. Biggers?
I couldn't have said it better. I think that it's so important to be to choose the people in your inner circle very, very carefully, so that you have people who support you, who love you, who can call you on things that you say that don't make a bit of sense. I could say that another way, but I won't. Okay. So let's just say call you on your stuff, all right? But do it in a way of love and in a way of genuine caring. There are so many people who just don't have your back. There are just so many haters out there. It's just so amazing to me that you can often see that you're surrounded by people who mean you no good. And so that's why I say you have to choose your circle, your inner circle, and the people who nourish you very, very carefully.
I know for many, many years, even myself in the beginning, when I first got diagnosed, it was suggested get a therapist, go get mental health. And me being a woman of color, I wasn't crazy. So I'm not going to mental health. And then they want to give me some crazy pills. The idea of imbalance, chemical imbalance and things like that, for many, many years in our race, we pushed that under the rug. We weren't getting mental health. You go to the church if something is wrong. Right. You don't go and get therapy. And I can remember even you say marriage counseling and stuff like, oh, nobody from the outside gonna tell me how to run my, relationship in my house. Those things are still happening. We want to say, we're getting better, but we still have a group of people that will not go to therapy because that's a sign that you're crazy. Or that what I'm thinking is not right. I'm gonna use myself as a for instance. So just this past week, I went to therapy on Monday. And normally, I've been an active member in my therapist, so I only go when needed or something. I showed her a picture this past week. She said, oh, you need to start coming back weekly. So she didn't get it. Okay, so a couple of years ago, I lost my son. So I went to the gravesite and I took a balloon that said congratulations. And so she saw it. I took a picture and showed her. And she said, congratulations. What's up with that? I said, well, he was always first at doing a lot of things, so he was first to go see Jesus. And she said, oh, you need to come back weekly. She didn't get it. To me, I knew why I did it. That was my thing. Hey, man, you still being first at the stuff you do. But she said, I need to talk about that because that wasn't normal. But, I mean, so, yeah, it was normal for me. It was my normal. But I am open to taking her suggestion and going back. But a lot of people wouldn't think, because in my real mind, I don't see nothing wrong with it. But, you know, but I am going to take her suggestion and go back and see. Because she said the medicine ain't working.
Hard to follow up.
I know. I guess as I was thinking and listening to the other three ladies here, for me, mental health, in the beginning of my diagnosis, as I reached out to spiritual advisors and I reached out to mentors and family members, everybody kept saying, you need to go see a psychiatrist. You need to go see it. And I'm like, I am not crazy. Like, I know I'm not crazy. And for the longest, it took me to get into mental health therapy. I tried it. And on the first day, I was like, that's it. That's it. But then I went back again, and they did this thing called a biopsychosocial assessment. They look at your biological history, they look at your psychological history, and they look at your social life and your social history. And that just broke it down to mind, body, and soul. And oftentimes in HIV care and continuum of care, the doctors, when they're working with us patients, they have to not just deal with the virus. Most times, I think that's the least of their worries because that's more manageable than anything today. They have to look at all of our issues. I often wonder, is my doctor okay when I leave from here? Because I'm pretty sure she either got down on her knees and cried and she's praying or something. I know she's probably losing it if I'm releasing all the things I have going on. So when I think of just mental health, I think of acknowledging that mental health is important. That's the first thing. And then understanding what holistic treatment consists of. Holistic means mind, body, and soul. So you just have to start with at least those two things that incorporate so much.
Yeah, I shared this, thank you for sharing that. I said last night, one of these common misperceptions that people were falling, the people who were losing to HIV are not weak people, And I think oftentimes the way we frame mental illness, crazy people, weakness, but there is a new vein in treatment and thinking about mental health. And Dr. Vincent, I'd love for you to talk about resiliency and some of the treatments that promote resiliency, because I think part of this is thinking about mental health as physical health, right? Just in spirit of that, if you could share a little bit with the audience about resilience.
Well, I think it's not unique to mental health, but medicine in general. And how we're taught in medical school, you look for diseases and you fix the disease. It's a really deficit-based model. You don't really look at a lot of strengths or health promotion or prevention. It's pathology, and that's the big course. And this is what we do when somebody's sick, but we don't think about how to help them stay well or develop into a healthy adult. And there's this shift that's happening in medicine and somewhat in mental health where we're looking at resilience. This idea that risk factors don't have to be predictive because of protective factors. And so doing things to kind of shore up those protective factors in people. And we've really just started to look at those in earnest, to be honest. But we're realizing that some of those things that spoke about earlier, relationships, a sense of purpose, just preventing people from being traumatized, giving them a place to speak and to have their voice heard, giving them a sense of identity that's not one-dimensional but is spread out over more things and it's more empowering to them, are all kind of aspects of resilience.
And building on that same line for the rest of our panelists, what are some of the innovations in both prevention and treatment that you're most excited about, solutions that you've actually seen work, whether it's in the community or the clinic? If you could share, speak about those.
First of all, let me say something about resilience and just acknowledging what you said about strong women, as opposed to women being perceived as being weak and victims and that sort of thing. I am just amazed at both the strength of my women, and these are my women, okay? I claim everybody in my clinic, they're mine, okay? I'm amazed at their strength. I'm amazed at how well my women and women just in general live with the uncertainty of being HIV positive, especially at a time when we just didn't know anything. I am just amazed, and I'm amazed at the resilience that so many of my patients, not just my folks, but just women living with HIV in general have, to come back from trauma that would take me down in an incredible way. I just cannot imagine my response if I had gone through a lot of what a lot of my folks tell me. So I'm just applauding that. One of the innovations, and I don't know if this is innovation, this is just my way of doing things. I like to have conversations. You can tell I like to talk, but I have a lot of dialogues with my patients. I really talk to anybody who will listen about sex. I talk about sex 24/7. I talk about HIV 24/7, but I think that is so important. I used to do talks at one of the AIDS service organizations, and my presentations were always the best ones. And wait a minute, no, wait, let me tell you why I'm saying that. I'm not saying that to pat myself on the back.
It's okay.
No, I'm not. I'm really not. I'm saying that because I recognized that it was not because of me that they were so successful. The reason they were so successful was because it was an opportunity for people to talk to each other. Often you go to the doctor and the doctor's saying, oh, blah, 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 and you're sitting there just listening. And you don't have an opportunity for your questions to be asked, for your questions to be answered. And I just knew that when I had folks in that hour, it was an opportunity for me to dialogue with them, for us to share ideas. And that always went over very, very well, as it always will. So is that an innovation? Not at all. I think it's common sense, but it works for me. And I think it really, really works for people to be able to talk, to be able to share, to be able to put their ideas, their thoughts out there, and for their thoughts and ideas to be respected.
I agree with you, Dr. Biggers. One of the things I know that a relationship with the provider makes a world of difference when we talk about secondary prevention. If you have a good relationship and are able to feel comfortable enough to talk about something or everything with your doctor, when she makes the suggestion of taking your medicine, being adherent, doing it in a timely manner, a lot of times you're more apt to respond because it's a two-way relationship. She's not just dictating, do this, do that. And another thing is believing in somebody. A lot of times, women, we're feeling already overwhelmed, down and out, and if you pay me a little attention or take a chance on me, send me to a training, let me get a certificate and feel good about me. I've seen women just blossom or change, when somebody takes a chance and, step up and
Some responsibilities.
yeah, and right, and it's like, wow. So then once you do that, it's almost like, okay, I got to continue doing it because they're watching me now. And so that helps I know it helps in the positive community. Now, for as prevention, I think when we do lively prevention innovations or whatever, involve something other than just basic dictating statistics, doing this. Get them up, get them moving, get them identifying with their own personal behaviors. So one of the things that Sister Love does, they do what they call a healthy love party. And it has different activities. And the activities in there get the person up and you list all the things that you call the body parts or the different sex acts. Everybody writes down whatever you call those things, and you get a chance to see how negative we talk about sexual acts. When you talk about knocking boots, do you really want to be with somebody when they say, I want to knock your boots? What is that saying about you and how you feel about yourself? Wouldn't it be better if we made love? So it's like teaching you how to talk about these sexual acts in a more positive way instead of always in a negative way. Or if you've done this particular event, you stand up or you sit down. So now it's giving me a chance to look at my behaviors and see what I can do to make them differently versus me sitting in a class and hearing, over and over. So we've got to come up with ways of making things different and interesting to capture their attention.
Mm-hmm.
I guess when I look at innovation, it's very simple for me. Peer counseling, having someone that I could relate to, it made a world of difference for me. And I've noticed that for myself, being a peer counselor as well, it has made a world of difference for a lot of people. People who I've known that I don't take medications for my mental health, but I do know people that need to and that do. And I'll never forget the time when I was working in the pharmacy, and oftentimes when you're standing behind the counter and patients come up, they never really look at you with your lab coat on as if you're a patient too. So I've had women that have told me if it wasn't for me sharing my story or talking to them, that they were afraid to come and pick up their medications. And that was a barrier, just the fact that the person behind the counter could possibly be judging them. But also, one young lady, it didn't matter how much mental health therapy I was in, it didn't matter how much mental health therapy she was in when she was seeing psychiatrists. When we both opened up to each other and took time in our friendship and could relate, not just being HIV positive, but also being a mom and a student and just having relationship issues with the guys that we were dating, that had opened her up to why she was even fighting herself, not taking medications. It had opened me up to why I was so resistant to even talking about being HIV positive. Not only that, it opened me up to realize that it was bigger than just me and being positive. It affected every person in my life, and it impacted them truly. So I guess just having someone to relate to really does bring on so much more innovation.
Stories save lives. I always say that. Stories save lives. We're actually at time, so I just want to, if you had closing thoughts that we didn't get to discuss, I wanted to give everyone an opportunity to share. Any closing thoughts?
Oh, I'm so disappointed that it's time to stop. I could just...
I could keep going.
I'm just having such a good time. I could just go on forever, as you can tell. This is such a, I just want to say, I just have to say, I'm so excited. It has been such an honor and a privilege, just an absolute privilege for me to have the opportunity to take care of people living with HIV. This has been, oh my gosh, I just cannot tell you. Can you tell that I'm excited about it? Can you tell that I talk about sex 24/7 and HIV 24/7? But it's such a calling for me, and I'm just always excited. I'm always excited to talk. I'm always probably talk too much, but I just want to say thank you so much. And Mary, my gosh, I saw the film right when it came out, and I was so struck and inspired. And just for you to be in our presence and give us everything that you've given us, as well as these wonderful panelists. My goodness, I want to take all of you home and just talk to you until you tell me to shut up. But thank you all. Also, thank you all for caring. Whether you're HIV positive or whether you're HIV negative, you care about HIV, you care about people, you care about each other. Thank you all for being here. It just means so much to me.
Stephanie, Masoni.
I say the same thing. I look out here and I see all the faces, and I saw the faces last night, and I wonder, how did we get the people to come out, and what can we do to keep them coming out? Because we're continuously having these informational forums, but very seldom do we get the crowd to come out and participate. So was it how we pushed it out, the advertisement, or whatever we did to make this happen? We've got to continue to do that on a regular basis so that we can keep the house full. And each one of us that have participated last night and today need to make sure we take this information and share it with at least one other person.
I guess in closing, I kind of look at it as an opening, a time to start new things and a time to get involved in a different way, in a different light. So I guess after leaving last night, I realized that there were a few people that came up and said they wanted to get involved. And every time people say that, I'm trying to figure out what way do they really want to get involved? And if they're really interested, who should they contact, like right now? Not 2 weeks later, follow up, a month later, oh, I saw you here, or I really want to do this a year later, because time is wasted at that point. If you are empowered or moved today, find a way to get involved today. Sister Love is here. Fulton County Health Department is here. They are here for you to contact them today to get involved, because there are programs that need help manning and volunteering for people to now start getting involved. Act Up, Fight Back, Fight AIDS. That was the fight then. It is still very meaningful now. It's just a different approach today. So today, I would love to hear Stephanie, Dr. Biggers, come back and say, Masanya, about 50 people came back to us and said they wanted to participate in the 2020. Or we got 30 people that want to present a Healthy Love Party on Georgia State University campus. Those things there, we need testing every Plaza Thursday. That's what I would like to see when we are closing in remarks, but opening up new innovations. Thank you.
Round of applause for the ladies. So next, I don't know if I'm introducing or... Actually, I think that's mine, but I'll get one. Okay, yeah.
Now it's their turn, right?
Mentioned about opening the conversation and having a really interactive program. We'd like to invite people to ask questions. If you could start lining up, there are 2 microphones here. And we'll take our first question from you, sir.
Go back there. Okay. My coat on. Get warmed up now. Just get
Alafia, I'm Kafria Biff, and I just wanted to say I really appreciate the powers to be to put this together. This is an awesome place to be in an awesome time right now. You know, there was a couple of things that just struck me, and I just wanted to, not really a question, but a comment, just four things really. Stephanie was really dead on about this thing about our self-worth and our self-efficacy. And we really have to create communities and create a space where people can feel valued for themselves. And if our young women aren't feeling valued, then other things can happen. But I also wanted to say that what we really actually have not uncovered is this enormous amount of sexual violence and trauma that goes on in our neighborhood. I'm not talking about, I'm talking about on our streets. I'm talking about down the street, around the corner, that has an everlasting impact on our women and our young boys as they grow up, right? Sister, Dr. Biggers, the thing, I know you up there in your doctor's hat, but this thing about our elders is, you had the Viagra and that, but the first of the month, these tricks come into these, let's be honest, if we're gonna talk, let's talk. All right? These tricks come in the first of the month and have sex with these older men, and then when the money's gone, at the end of the month, they're in there with the rest of the women. That's what's really happening. That's what we really need to talk about, right? In terms we need to really talk about things in these real terms that people are going to understand, right? Definitely. The psychiatrist, one of the things that I think as a community, you talked about what doctors do. We talk about treating the pathology. But we as a community, we have to get to some place of health promotion, disease prevention. And that's a responsibility that we need to kind of figure out a way of health promotion, disease prevention, and us changing that format, changing that paradigm about us not engaging in our own health, and we can do that. Thank you.
Hi, Vicki Cargill from NIH. It was a wonderful panel, and I too had comments more than questions. I wanted to first come to the point of stigma, because I think what was mentioned about how, I believe you mentioned that you felt that you didn't have worth and didn't want anybody to touch you. We actually know there's several different types of stigma, and I think it's going to be important that we get comfortable with that language talking about what it is, because if we don't talk about it, what happens is then stigma itself grows like a monster in the closet and continues to take over. So someone can have, self-perceived stigma, but then what happens after that is they hear stories about how other people with HIV have been treated. And that then becomes something that informs them, and it becomes a different type of stigma where now people actually are hyper-vigilant for it. And the backside of stigma is some of the very people that are busy stigmatizing people and have things to say, as you mentioned in the pharmacy, some of us have to be willing to step up and call people out on that. I was in a clinical session and I heard someone I practiced with a couple years ago call a woman out for being pregnant and she being HIV positive. He actually said to her, "What part of spreading this to your baby don't you understand?" Now, I had a choice. I could sit there and wait till my clinic session was over as I'm trying to engage a patient who's looking at me like, are you going to talk to me like this next? And those who know me know, no, I don't. I go to houses. I make home visits. So now that's on the line. But I also couldn't have let this happen because otherwise she leaves thinking the rest of us are like this. So I made the choice. I left my session. I interrupted his session. I pulled him into the pharmacy closet and I told him, you either need to go back and apologize. We have to go to the director because you need to go. You can't do that because otherwise we are perpetrating violence on our patients. And that's completely unacceptable because the last time I checked, when I raised my hand, being violent to my patient wasn't part of it. That's right. And the second thing I will say about health promotion, we are absolutely right. We are very creative people and we need to use that creativity to build our resilience. And we've been doing a lot of work at NIH on resilience. But please, let's not use our creativity to come to the point that we excuse behaviors that we know in our heart of hearts isn't okay. If you are 5'2" and 400 pounds and have a hemoglobin A1C of your diabetes of 22 and I tell you you're going to lose your kidneys or your eyes or your heart, I'm not playing with you. Let's talk about ways we can do it, but please don't look at the height and weight charts, and I know I'm not the thinnest person in the world, so I'm not throwing stones, but please don't look at the height and weight charts and tell me they were created for white people. No, they were created for human beings. And your health is important to me. That's why I'm talking to you.
Monty Norwood, Bible Way Ministries International Church on the south side of town. And I'm excited about this forum. Appreciate what the panel had to offer, and especially the suggestions that were given in response to my question last night. My question is, what impact does the refusal of the governor in the state of Georgia to extend Medicare and Medicaid to nearly 500,000 underinsured and uninsured persons, what impact does that have on this discussion? What can be done?
A lot. I mean, you know, we didn't get into the whole policy discussion that much, given time constraints. But obviously, my opening comments about DESEs, right? That's structure right there, right? I mean, it has a huge impact. And I think in general, one of the things with the Affordable Health Care Act, you have to remember, in the history of HIV in America, what we did, because we didn't have universal coverage in this country. Mind you, we finally did it in the 21st century. Most of the world did it in the 20th and in the beginning of the 20th. So we're 100 years plus late on that, is that we created an entire separate parallel care system for HIV patients, right? So part of what the innovation and part of the history of HIV in this country was actually getting us to think about the distribution of healthcare differently as well. So it's a huge problem, huge problem. And it goes back to what Ms. Sonia says. That's why everyone's got to write their congressman about this. Everyone's got to get involved about this, right? That's how those kinds of changes happen. So huge, huge parts.
I would just remind you all in your program, because I think that's a brilliant question, in our second panel this afternoon, State Representative Simone Bell will be here to address some of those directly. So just remember that, and that means, you know, you can get your lunch and come back.
Hello, how are you doing? I am Reverend Vanessa Sharp, and I am board chair for Sister Love. But I just want, and I'm also on the Presidential Advisory Council of HIV and AIDS. I just came back last week from Washington, D.C. So you hit on a lot of very important factors right now. First of all, I want to commend the women that I see up front. It's refreshing to hear new voices that are coming to the forefront and speaking about issues pertaining the health of women. I've been in the trenches since 1996, diagnosed in 1990, and you don't know who's watching you. You don't know what impact you can make, but I can tell you this. When you open your mouth and you speak from the heart of the matter, because you're not thinking about yourself, you're thinking about the welfare of all people concerned. This is a health issue. And we try to make it be a gay issue or people who are on drug issues. It's not even about that. If we would erase that factor and focus on humanity and recognize that it is a human health disease that needs to be rectified, addressed, and corrected, reversed. We talk about 2015 being the deadline of no more infections, but yet we're still so far from that mantle of getting that accomplished. And Dr. Bigger, I need to see you after this is over with. I love you. And when you've gone around the globe and been able to interact with people addressing HIV and AIDS, and when you open your mouth in Africa and they've never seen a person of color who has lived longevity, all they've seen is death. And you can impact a community of 11,000 people just because they see a visual person. It helps a person want to live and not die. When we open our mouths, it helps a person reconsider their position, change their mindset, and realize, I can beat this thing. And that's why it is so important for us to continue to have conversations like this so that we can help people desire to live their lives fully, to whatever capacity that is not called by man, but called by God. If it hadn't been for my voice hearing the voice of God, I would have allowed myself to die in 1996. But God promised me that I have the plans for you, a future and a hope. Trust me, and I will guide your steps, and I will open the doors for you. And everything I desire for you to do, it will come to pass. That's the medicine that I received that helped me to move forward and be here 24 years after hearing of that diagnosis. The medicines helped. The medicines helped, but relationship with God helped even more. So I'm just here to encourage you. And about the Medicaid expansion, Georgia is in terrible trouble. And I heard it from the head. And so we need to get on board and go to our congressmen and speak our voice, because we're allowing ourselves not to get the best care and coverage that can possibly be made because we won't open our voices. Thank you.
These are the last two questions. So, sir, if you could. Do you have a question?
I don't have a question. It's more of a comment. I know this female is in my neighborhood. She's very beautiful. You would call her a living doll. Got the green, gray eyes, you know, and very attractive. And she applied for disability from Social Security. They denied her. She had the 3 H's. She had the hepatitis C, herpes, and HIV at the same time. And Social Security denied her benefit. And that's 2010. I think she just recently, they changed it and gave it to her. But, you know, with that weight, you know, I mean, just how sick you have to be before they even recognize that, you know, you're disabled, you know. That's really a comment I wanted to make. And she's still out here, you know, she's on her drugs, you know, so she still spreading this stuff, you know.
Bureaucracies are hard to penetrate, you know. I've seen the way claims get processed from the inside, and there's no justification for it. That's why you need to be so loud and persistent, right? Loud and persistent. And it's crazy that, you know, that's obviously a right. You would think it'd be a lot easier, but the machinery of how claims even gets processed and requests by the federal government, it can be a whole separate 2-day symposium. And I think it takes true vigilance, you know, even for the most empowered of us. So, unfortunately.
My name is Trovell, and I just want to respond on about the mental health issues and stuff. You know, for me, when I dealt with my mental health issues, you know, I never knew. I don't like Stephanie. When you finally start to deal with your mental health issues, how did you? I mean, you start to feel better about yourself. I know for me, my question is, for a person who's been living with HIV for over 23 years, I still struggle with my HIV, and I'm in therapy. So how do we, persons who are long-term, because I still struggle. I do speaking engagements, I talk about HIV all the time, but sometimes, there's some days that I struggle with my HIV. How do I deal with that on a mental capacity? Because some days I do struggle with my HIV. And it can be, and some days can be very discouraging.
Please.
Because some days some days are fine.
Here,
some days I struggle with my HIV, and I've been HIV for a long, long time.
Yeah, Trovell, I, like you, have 27 years being HIV positive, but I use people, I use God, I use myself, I use the love that I carry within. And you, Trovell, have that love. You have that. You advocate. We all are advocates in this room right here. And for me to continue to be strong and to deal with life on life terms, I use each and every one of you. I take it to God. I take it to my doctors. I become friends. Socialize. We just got to keep moving on. That's all I got to say.
I just want to add, and this is, I think Lisa said this last night, just remember, we all struggle, right? You are not alone. It is not just an HIV thing. And I think that's one of the biggest messages moving forward into the next 20 years. You know, health is health. We started out saying HIV is part of public health, right? It's part of wellness. It's part of like being well in the fullest way possible. So you're not alone. Just remember that.
Let's give our panel a round of applause. Thank you all so much.
Just in case some people slightly forgot in between the questions that were in comments that were just made, thank you. Involvement is very important. I am one person and I do my speaking engagements. I go to many places and everything, but I really, really want to stress that some of the people that are here, open ears, you can hear, you can see, you can understand. Your involvement is so important right now. That is the biggest thing that Atlanta needs, is your involvement and participation. So please don't forget, that's the only thing that I can stress. Thank you.
Can you hear me? All right. So I'm Brianna Kelly. I am a community services specialist in the Community Engagement Corps.
Hi, I'm Shara Heffernan.
Okay. And this is Sunday. So what we're bringing to you today is we want to talk about an excellent resource that we've created at the Community Engagement Corps. I have created a mobile application for resources in the Metro Atlanta area. So hopefully we can get this up. And if not, then that's okay, because we'll have a few slide printouts of the slide available outside, and we can get your information if you want to know more about the application. So as it was mentioned earlier, the CoEx was funded by the National Institute on Minority Health and Health Disparities. We were given a 5-year grant really to do research about minority populations here in the Metro Atlanta area and health disparities. So this app was created, the idea was curated by Marianne Adams, who you heard a lot about today, and Dr. Ying Zhu in the Department of Computer Sciences. So we collaborated because that's what we do in the Community Engagement Corps to bring this product to you all. And hopefully you'll see our slideshows because we show you how to use it, but I know it's time for lunch. So how this idea started is staff in the Community Engagement Corps were doing research in the community, and what they realized was there were a lot of community members who weren't aware of resources available right here in the Metro Atlanta area. So we found that to be problematic. So we started with a community manual. It was a printed out book to address literacy needs, because we know that some folks don't have high literacy skills. We had it color coded, we had maps, we had bus routes, we had all of that great stuff. As you know, with any community resource guide, it immediately becomes outdated because stuff changes all the time. People lose money, people change names, services close. So that was one issue, but surprisingly enough, well, not really surprising because we know people are always in need, the demand for these resource managers just continue to grow, and printing is expensive, so that kind of became problematic. So we know in the metro Atlanta area, we have lots of issues. We know we don't have Medicaid. We know we have a high unemployment rate, all those things. And what does that tell you? People are in need. People need to know about these things. So this app, how it's unique and different from any other app, community resource app, which we were unaware of or we weren't able to find. We found a really good one in Singapore. But that doesn't do us any good here. Is we can update it in real time. We can physically go in and change the resources from our computer. So the problem with resources becoming outdated is something that this app doesn't have. We also integrated it with the Google Maps, so it has all the functions of Google Maps, so you can get walking directions. It does bus routes. It talks to you. I don't know if anybody's familiar with it, but that was a bonus. The resources in it are appropriate for members in the community who need it. We were very specific to address things that our communities needed. So Shira's going to tell you a little bit more about that. And then we also included national numbers because we know that there are national hotlines, crisis hotlines that are also important to individuals. So Shira is going to tell you more about the functionality of the app, and we'll have a sign-up sheet outside if you want to be notified when it's released.
So hopefully the screen will start to work because a lot of it is going to be shown. But I guess I can go ahead and tell you a little bit about it. Basically, to access this app, you can go to the Google Play Store. It's also going to be available soon on Apple, or you can download it on the web. Thank you. Sorry, guys. So this app is exceedingly easy to navigate. It has over 14 different categories of resources addressing different community needs. There's going to be an icon that you can download on the Google Play Store. The browse function, which I would show you if I had the screen. There's an interface, and basically it has 3 unique features. So the browse function allows you to browse through all the different categories, and the search function allows you to search for a service specific to what you're looking for. So say you're looking for food. You would enter in food, and all of the different types of food resources would come up, and then you would know where to go. The resources are color-coded. We did this so it would make it easier to navigate through the categories and find what you're looking for. We also wanted to address literacy issues, so we did icons next to each of the resources to help you identify. So for example, you would see if you were looking at the actual resource, it has an HIV and AIDS assistance category, and next to it has a red ribbon. And then if you look at the fork and knife icon next to the food and clothing resource, and then there's also a house next to the house icon. So hopefully we'll be able to show you this shortly. The app also has Google Maps, which we thought is unique because it gives you driving and walking directions along with bus routes. Which is great. So there's a little icon at the bottom right of the app where you can click on directions and it will actually show you how to get there. It also has a print feature where you can print out a copy of the resource and take it with you. Once you select a certain resource, like Sister Love, which is available on the app, you can see the address of the organization. You can also see a description. You can see the services they offer, phone number, fax number, and email. Other resources, like under the HIV category, offer different types of services. Yay. Okay, let's go to slide number 9.
What I was going to suggest, just to kind of keep us on track on where we are, is that anybody interested in actually seeing the app and what it looks like, if you would come back from lunch 10 minutes early, so instead of being back here at 1:30, at 1:20, we will run through this presentation again so that you can actually see how the app works. Does that work for everybody? Improvise? All right, I think at this point, we will break for lunch. There are box lunches outside. Please feel free to partake of lunch. And again, we'll start this app presentation at 1:20, and we will begin the second half of our symposium promptly at 1:30. Thank you.